Hello, my name is Zoe Chasnick. I am an occupational therapy doctoral student at the University of Indianapolis, and this is my capstone project covering prevention of deformational plagiocephaly in the NICU at Eskenazi Hospital, downtown Indianapolis. So with my project centered around preventing deformational plagiocephaly, let's go ahead and define what that is. So DP is technically classified as any changes in head shape that result from external mechanical factors, whether that happens in utero, during birth, or postnatally. However, it is important to also know that an infant's head shape does often occur with some cranial molding during the birthing process, and this usually should resolve 6 weeks after birth. So any head shape abnormalities after that 6 week mark is what we consider deformational plagiocephaly, which is also known as positional or non-synestotic plagiocephaly. So why is this relevant in the NICU, and why is my project taking place here? While DP does not apply to head shaping changes noted until after 6 weeks of life, prevention is best when completed as early as possible, especially since infants in the NICU are at a higher risk of developing flat spots as they grow and recover in their NICU beds. It is also important that preventative care begins in the NICU, as Eskenazi's infant clinic continues to report high percentages of babies with some sort of asymmetrical head shaping issue. These babies are also being referred to helmet therapy, whose effectiveness has actually been questioned in recent research, and overall is stressful and costly to families, so this is just something we'd like to prevent in general. Research has also shown that there are potential negative effects and outcomes for untreated and delayed treatment DP cases, such as being a marker for developmental delays or acquiring other conditions such as torticollis. For my more in-depth needs assessment, I conducted a pretest survey which had a total of 25 respondents. These respondents varied from therapy staff to nursing staff, NMPs, as well as other medical staff. This test showed that there was high awareness of deformational plagiocephaly, but really low confidence with integrating those cares and limited knowledge on the available treatment options that are more conservative and preventative, such as repositioning. Therefore, my project aimed to create an educational program in the NICU for staff to increase that confidence and competency in recognizing DP and addressing prevention during routine infant cares. For my project's theoretical background, I used the Model of Human Occupation, or MOHO, to develop and implement my project throughout the entire experience. And this little diagram shows how I kind of did that. So you can see that we have MOHO's main principles of volition, habituation, and performance, and how looking at infants and their development, their sensory experiences, and wanting to provide holistic care all kind of goes into that motivation piece. That was kind of what my pre-test survey was also doing, was kind of raising awareness that this project was about to be implemented, showing that evidence that yes, we really need to start putting preventative measures forwards versus just not addressing it or not addressing it as often as we should. And therefore, the possible outcomes that I'm hoping for is that with increased motivation and wanting to become more competent, staff will increase that confidence and competency, and hopefully we will start to see decreased incident rates of DP in their infant clinic. So now on to the education piece of my project. So I created a PowerPoint presentation with a voiceover that I shared with staff, and you can access this via the QR code here on this slide. The main objectives of this education were to define DP and its causes and associated risk factors, to discuss current NICU observations I was seeing in regards to head shaping and head turn preference, as that is an associated risk factor for developing DP. We also explore the impacts of DP and how it's more than a cosmetic concern, And we also reviewed assessments and interventions for DP and how they can be utilized very easily in the NICU and implemented into everyday routine cares. We also defined further concerns associated with DP, such as that developmental delay possibility and how they can play a role into preventative care. So this educational presentation was also going to be submitted to Eskenazi's HealthStream e-learning modules in the future. This will make it more mandatory for staff, and it will be either a biannual or annual education. I also created supplemental materials to maximize engagement among staff. So these were in the form of staff guideline packets, as I called them. They were in folders in multiple locations around the NICU for staff to access. And these folders contained a packet of staff guidelines supported by the educational presentation they received. There were also copies of educational handouts for caregivers and parents in English, Haitian Creole, and Spanish, as well as French, as these were common languages I was noticing around the NICU, just to help educate parents at discharge. There's also going to be a sample head of bed rotation schedule, which I'll talk a little bit more about on the next slide. This is for staff to utilize so that they're routinely changing the head of bed orientation in the room to help address head turn preference and therefore address preventing any flat spots from forming. There's also a head turn preference home exercise program in these folders for staff to utilize as well as to provide to caregivers and parents upon discharge. So here is that head of bed rotation schedule I was talking about on the previous slide. So what this does is addresses head turn preference in a way. So let me explain a little bit further. When the baby is in a certain room, usually the door will be on their left or right side, and then there's a clock on the opposite wall from the crib. So what we're trying to do is have on odd calendar days, the baby's feet are facing away from that clock, and on even calendar days, the baby's feet are facing towards the clock. This changes the head of bed orientation on every other day, and this helps the baby turn their head both left and right as they will be getting different stimuli from different sides of their head. So if say the door is on their left side here, if they're getting stimuli maybe from light or noise out in the hallway, they are more likely going to be turning their head towards that side, putting pressure on that left side. But if it's switched, then we are then now going to the right, taking that pressure off the left side, now putting it on the right. This just helps really shape the infant's head and make sure that pressure is being relieved on both sides while also having the baby turn left and right to help with exploratory play as well. We were also running into the issue where sometimes cribs were being parallel to the wall, so only one side of the crib was accessible. And this was an issue because, one, we need both sides accessible, so if there is an emergency, that medical staff can address the baby from both sides and there's enough room. Also, keeping it perpendicular to the wall will help with that head turn preference as well. And then here are the different QR codes that you can access to see all of the supplemental materials that I created. And I'll touch a little bit on what each handout kind of has. So for the staff guidelines, what we're really trying to highlight is that we really want to give the infant active movement breaks after every diaper change, as well as maybe 2 to 3 minutes of tummy time. So active movement breaks are going to help with that head turn preference so that the baby's moving their cervical muscles to look left and right. And tummy time completely takes pressure off the back of the head and helps with that shaping as well as just really supporting their overall development in a healthy, safe way. This guidelines packet also goes over ways that you can do repositioning and preventative care for stable infants as well as medically complex infants. It's a little bit harder to address plagiocephaly and plagiocephalic changes for medically complex infants, but there are ways that we can safely do so. The caregiver discharge education just goes over what deformational plagiocephaly is, when you should talk to your doctor if you notice flat spots developing, and why we're trying to kind of prevent that. We discuss a little bit about helmet therapy and how it is costly and stressful, and how we're just trying to prevent that for families. So we're giving them the education now so that they know how to address head turn preference at home. They know that they should be doing tummy time, while also still following the safe sleep protocols. Like, just because we're having them do tummy time doesn't mean the infant should be sleeping on their tummy. They should be sleeping alone and in a crib and on their back. Addressing head turn preference handout is the last one listed here. And this is just giving a home exercise program for caregivers, but also just shows ways that staff can use these in the NICU as well. It's 2 exercises. One is just talking about tummy time, which staff should be implementing after every diaper change or after every hands-on care for at least 2 to 3 minutes. And then the other exercise is kind of a side carry football hold. It has that baby facing away from you while you're holding them in your forearm. And depending on which head turn you want to block, so say they have a preference for looking to the left, we want to try and block that with our body and have them look to the right, just to stretch those muscles out and hopefully help the baby start wanting to look left and right. And this is an easy, simple carry that you can show parents as well, which is what we're trying to implement. So I showed this a lot to staff in person, and then help them be able to educate caregivers at discharge on those certain strategies. Now we're going to touch a little bit on engagement and participation with my project throughout this experience. With the educational presentation, I only had 19 participants, which mainly included nursing staff and NPs, as well as the speech therapy team. Thankfully, 100% reported they were likely to implement more preventative practices into care, and 100% also reported the education being valuable, with 15% reporting extremely valuable and around 84% very valuable. So while engagement was necessarily kind of low, I was still seeing some positive feedback from that educational piece. So the education that I provided via the presentation format was what we considered live to staff for about 2 weeks. And once that closed, I had a post survey. And I only got 7 responses, which was all nursing staff, but I did have some pretty positive feedback just from these 7. All of them reported increased understanding and awareness of DP in every single category that we addressed in the presentation. So they were more aware of the risk factors. They were able to define DP to their peers as well as to caregivers upon discharge. They were also more confident with integrating preventative techniques into their routine cares, and they understood the importance of prevention and were really, really a lot more confident in applying that knowledge. I was having nursing staff come up to me and asking really good questions and asking for direction with how they should be educating parents at discharge, which was really awesome to see. And 100% of them, so all 7, had already begun implementing those preventative care techniques that were discussed in the presentation, which I was so happy to see. So like every project, there were challenges as well as successes. So a big challenge for this project overall was participation and engagement. So while that was relatively low and was not really expected, I expected a lot more participation as there was really high interest upon my arrival to the NICU. And even though that was low, interest was still really high, and curiosity was really high, and they were all asking appropriate questions. So I feel like this will, down the road, increase more engagement, especially now that the education that I provided will be submitted to their health stream, so they will be getting that mandatory education. Another big challenge was technological difficulties. It was really hard at the beginning of making the educational presentation live that staff was having a lot of issues being able to access it. So I had to keep changing the format. It was a really easy fix, but we had to jump up through a couple hurdles until we got there. Another challenge was the language for the caregiver handouts since the population around downtown Indianapolis needed to be addressing them at more of a sixth grade level. It was really hard to get that language down just for health literacy reasons, but utilizing pre-existing handouts that they had to match the verbiage really, really helped. So while there were bumps, everything kind of smoothed out in the end. So lastly, I just made some suggestions for continuity of the project. Beyond just submitting to Eskenazi's health stream, which will make it mandatory and really get more outreach amongst staff, I also suggested that there should be group education or one-on-one education sessions to show those preventative care techniques that I suggested. They have baby dolls all around the NICU, so they could practice with that. There's also the chance that they could even practice on stable infants with OT. We could also schedule classes. I know that my OT mentor, she was part of the onboarding education for nursing staff. So maybe implementing classes of that in some sort of way and just continuing the encouragement or continuing encouraging use of the staff guideline packets and folders and the head of bed rotation signs as indicated. We were using those head of bed rotation signs once the baby was ready for safe sleep. And even before I left, those couple weeks leading up to leaving, staff was utilizing those flawlessly. It was really great to see. And these are my references. I also wanted to take a second to acknowledge and thank both Eskenazi Hospital as well as the occupational therapy team that I worked very closely with at Eskenazi in the NICU. So that would be my mentor, Terry Rexrow and Alyssa Snorek, as well as Taylor Gurley as my advisor from UIndy. Thank you so much for everything, and this was an amazing experience.